You are now listening to MedEd Talks Cardiology, a Vindico Medical Education production. To view the CE information and claim credit, log into mededtalks.com and search Lipid Legends Season 2, or click the link in the notes section of this podcast. Now, here's your host, Dr. Underberg.
Hello, and welcome to the Lipid Legends podcast series. This continuing education series is supported by educational funding provided by Amgen, Arrowhead Pharmaceuticals, Inc., and Novartis Pharmaceuticals Corporation. I'm your host, Dr. James Underberg, a clinical assistant professor at of medicine at the NYU School of Medicine and the NYU Center for Prevention of Cardiovascular Disease. I'm also the director of the Bellevue Hospital Lipid Clinic and past president of the National Lipid Association and past president of the American Board of Clinical Lipidology. I'm joined today by my colleague, Dr. Don Wilson, fellow of the National Lipid Association, a diplomat, the American Board of Clinical Lipidology, also a past president of the American Board of Clinical Lipidology, and an endowed chair of cardiovascular health and risk prevention for pediatric endocrinology and diabetes programs at the Cook Children's Medical Center in Fort Worth, Texas. Don, thanks so much for joining us today.
Well, thank you for the opportunity.
We want to jump in this Lipid Legends podcast series. I've had the pleasure of interviewing expert physicians and researchers on topics that are of current importance in the field of clinical lipidology. Today, we'll be discussing the evaluation and treatment of pediatric lipid disorders, including familial hypercholesterolemia, heterozygous familial hypercholesterolemia, and homozygous familial hypercholesterolemia, and also lipodystrophy. But before we get started, I always like to get to know our discussants. So Don, how did you end up in the field of pediatric endocrinology and lipidology? I always love hearing everyone's short story there.
Well, thanks for your question, Jamie. I started out classically trained as a pediatric endocrinologist, doing a variety of endocrine-related disorders, a lot of diabetes, a lot of growth disorders, thyroid disease, as you might imagine. And I've been at this for about 45 years. So about halfway through my career, it occurred to me that a lot of the kids that I took care of back in the early 80s were unfortunately having some severe problems, and some of them had actually passed away tragically. So I took a step back and sort of asked the question, what's the problem here? I mean, what are these kids dying of? And it turns out that, it's not the diabetic ketoacidosis that we struggle with during adolescence. It's actually cardiovascular disease. So I set upon a journey to try to figure out what that was all about. And then, is there anything we could actually bring to pediatrics that would actually improve the longevity and quality of life of these young people? It's tragic that anyone dies at that age. But I felt somewhat responsible that I wasn't doing enough for those kids.
That's a great story, and it's really great to hear how we all came to this field from different directions. Of all the things that you've accomplished over the course of your career, what achievement are you most proud of?
I've had the privilege of working in several major institutions, but three in particular: Texas A&M University of Arizona, now Texas Christian University in Fort Worth. I've set up lipid clinics for children in the community. And then as I've moved to another organization, I've had someone take over those clinics. So those communities are actively engaged in screening and then appropriately counseling families about particularly familial hypercholesterolemia, and then initiating, when it's appropriate, lipid-lowering therapy in those young people. So we think that effort is going to pay a lot of dividends. In fact, we have some proof to that effect in the long run.
Kudos to you. Congratulations. And it always makes all of us feel good to see the fruits of our labors over the course of our careers. So getting to the topic at hand, when we think about some of these pediatric lipid disorders, homozygous and heterozygous FH, lipodystrophy, etc., why is it so important to recognize these abnormalities early in the pediatric process?
Well, because most of these things are actually genetic. They're either monogenic. We all know about heterozygous FH and homozygous FH, but there's also a polygenic component. So For example, the kids that we're seeing who have diabetes mellitus or obesity or those sort of things, they have a polygenic background that may make it particularly concerning long-term in terms of their cardiovascular risk. But a lot of these are genetic, and so they're present from birth. The thing that we've been very pleased about is that not only do we identify young children with these disorders, and since, for example, FH is autosomal co-dominant, we know that one of their biologic parents is probably affected. And so we're dealing with a young population who have young parents. Many of these parents have never been diagnosed, nor do they know they have FH. And so I think we've done a service, particularly, they're a little closer to an event. And many of these folks have actually had significant elevations of their cholesterol, significant family histories, and some of them actually turn out to have some ischemic events. So I think by sort of working upstream from the child, we've been able to help a lot of the parents as well.
That's great. That's great. And any barriers that you have to deal with in the role of managing pediatric lipid disorders with regards to screening, treatment, family, interactions, et cetera? A little different than adult medicine.
That's true. And, we take the job and responsibility of children very seriously because, any medications over a lifetime has some concern associated with it. So we don't have a lifetime of experience with treating children, but we do have a 20 or 30-year history. And we've been very gratified that statins in particular have been quite safe, and they also reduce cardiovascular events when young people get to be at least 50 years of age. Beyond that, we don't have a whole lot of data, but we look at what happens in the adult world, and we think that we're actually headed in the right direction. But in terms of barriers, I think the real issue is really initially educating primary care physicians, pediatricians, and family physicians. And I think there's still, to this day, some misinformation or misunderstanding because, let's be honest, most physicians are not either trained currently to look for FH, and most of the things that they see in their clinics are going to be obesity related, because we have so many children that have obesity and obesity-related complications. But cholesterol screening in children is really all about looking for FH. And so we have to kind of overcome those barriers. We want physicians to make independent decisions about their practices and their patients based on evidence. But I think the evidence suggests pretty strongly that screening kids for FH is very cost-effective, and it's also very effective long-term in reducing cardiovascular events, morbidity, and mortality.
Are we getting better at pediatric screening? I know there have been a lot of hurdles in the past, even some infighting with regards to organizations and societies.
That's true. I mean, I think pretty much all major health organizations that deal with children are pretty much on board with screening worldwide, by the way. I think the issues really now have come down to practical issues in terms of physician time. And so I think we have to respect that because pediatricians, family physicians are increasingly asked to do a lot of anticipatory guidance, conversations about vaccines and vaccine safety. And so somewhere we have to kind of plug in the screening without being intrusive in their practices. Again, a lot of the pediatricians are not comfortable counseling families about FH because it wasn't part of their training. But I think we're getting better at it. I think we now have enough people like myself who do pediatric lipid disorders that there's at least on a regional basis, if not a state basis, someone that is a go-to person. So with the telephone or with the telecommunications, it's easy enough to pick up a phone and talk to someone about it if you're uncomfortable.
Yeah, that's good news. It's great to hear. So moving on now, if a child presents with severe lipid abnormalities, obviously we don't have time to go through all of the diagnostic criteria of every lipid disorder, but thinking about heterozygous, homozygous FH, maybe lipodystrophy or one or two other common things that you see, what are the key clinical laboratory features that you're looking for just to start the process of diagnosis?
Well, again, from our screening efforts, and they're getting much better, but from our screening efforts, you mentioned barriers. One of the barriers is the concept of fasting. So if you look at the data, and there's plenty of it, fasting doesn't significantly or clinically significantly impact LDL cholesterol, and that's really what we're after. Now, yes, there are some children that have modest elevations of triglycerides, but that's a different story. We're really looking for FH, and so we would encourage people to embrace non-fasting lipid profiles because only about 10% of the kids are going to have an elevated triglyceride levels. And most of us are a little bit biased because that's what we get referred in our clinics. So you have to assume that this is a general population in a pediatric practice. But a better strategy is to do all the kids because it's very inconvenient if you're going to do fasting and you have patients all day long. Those kids have to miss school or be late. The parents have to miss some work. It's just not very popular. So at the end of the day, if people would just embrace doing non-fasting, then that small portion of kids that have elevated triglycerides, but let's say over 200 is a reasonable number to assume, then you can logically say, we're going to bring those kids back and evaluate them fasting. And they may also benefit from other diagnostic tests at the same time, like looking at their thyroid, renal function, kidney function. So you get 2 for 1.
But what are the numbers that you keep in the back of your mind for diagnosing FH, heterozygous FH, homozygous FH, and what are the diagnostic criteria you use for lipodystrophy?
Yeah, so good question. To make it simple for our primary care physicians, there's some nuances to this, but in general, we tell them, look, if you have a child who, at whatever age, has an LDL cholesterol of 130 to 160, then that child and family needs some dietary counseling. You also need to take a good family history. So you might be a little more aggressive on that child if there's a significant family history, or one of the parents, for example, has known hypercholesterolemia, taking lipid-lowering medications, for example. If the level gets to be 160 and you're pretty confident in that, perhaps you might want to repeat it, then we ask them to refer those so we can kind of do the workup for them. We take that off their plate because they're just so busy. If you have a sustained level of greater than 190 and the child's been given counseling regarding dietary modification, lower fat diet, and increasing physical activity if they're overweight, try to help them with their weight management, then that's the child that we sort of really focus on in terms of treatment. We may also treat those kids between 160 and 190, depending upon other risk factors. So, there are a lot of criteria there. I think for busy clinicians, they're a little bit too complicated for most of them. I just say 400. You get to 400, and you have to convince me the child doesn't have homozygous disease.
I think that's a great number, yeah. And what about lipodystrophy? I mean, this is a disorder that even a lot of endocrinologists struggle with. This something that you see a lot in your practice? And what's your thoughts on the diagnosis?
I don't know how prevalent it is. Now, the true generalized lipodystrophy is very rare. We do have some of those children in the clinic. They're a little bit easier to spot because they just look totally emaciated. The kids that have partial or developing lipodystrophy, and there are a variety of reasons, one of which is genetics, but those are harder to pinpoint because a lot of times we don't disrobe the kids. It's uncomfortable, it's embarrassing, and so kids don't get disrobed. But you can start picking up this, particularly if they have it affecting their limbs, like their legs look very muscular. And the reason for that is because they don't have any fat around the muscles, right? Their veins look very prominent. You may get some kids, as we have, that are self-conscious about their appearance. So they'll say that, they don't look like other kids. Particularly in the state of Texas, kids wear shorts, short pants and so forth, almost year round sometimes, or bathing suits. So sometimes we pick them up that way.
So let's move on now. We've talked a little bit about how to think about and recognize some of these conditions. If we start with familial hypercholesterolemia, let's start with heterozygous FH. You've already mentioned the importance of lifestyle, and I think that's so key and important, and you don't want to underestimate the value of that, both as an initial therapeutic intervention and as a lifelong intervention. And then you've also mentioned statins. So after statins, what are your other options in kids for managing familial hypercholesterolemia?
Well, here's the real good news. Vast majority of the kids, a single statin, if you get the right dose, is about all they're going to need. Then the biggest challenge you have is just compliance. It's not because the kids have any adverse effect. I can't tell you that I've ever seen a child with an adverse effect to a statin. In fact, I don't think we've ever taken any child off statin. But kids are active, they're healthy, they're engaged in a number of activities, and at the end of the day, they just sort of forget their medication. So they have to have a routine, and then we typically will monitor their levels every 6 months or a year, depending upon how they're doing, just to make sure that they're on target. So it's not usually a problem. If If you start a little bit higher than the recommended dose of the lowest dose that you can get, I think you'll get there, particularly if you start with an LDL cholesterol of 250, starting with the lowest dose, unless the parents are apprehensive, is not going to quite get you there. But let's say you have someone on a Torbit 20. Kids will tolerate that quite well, morning or evening, with or without food. So it's as easy as you can get it as far as taking it, right? And then if we need to further lower their LDL cholesterol and their compliance is good, that's a big if sometimes. We'll add ezetimibe for two reasons. One is we'll get a bigger reduction in LDL, 15 or 20%, as opposed to the 6% going from 20 to 40. Number two, sometimes we're concerned that there is a dose response with regard to side effects. So we rarely get to 40 or 80 on atorvastatin, or 40 on Crestor or whatever, or 40 milligrams on a rosuvastatin. And the other nice thing is they don't seem to outgrow their dose, right? The parents will ask that question, is they going to need more therapy as they get older? The answer is probably not. If you remember the Scandinavian data, that's our 20-plus year follow-up, they're treated with pravastatin. So it's not a very potent statin, but it actually works quite well. So heterozygous is not usually a problem. We rarely have to go to injectable drugs. We do have a couple of children that have autism that also have confirmed genetic FH. And those kids actually do much better with the injectable drugs, if you can believe it, because they have oral aversions for therapy. So you can try oral therapy. Most of the time you're going to fail with that. That's okay. Maybe they can come back to it later on, but the injectable drug actually works pretty good.
So both alirocumab and evolocumab, you can use them in children, correct?
Correct.
That's great. So there's a lot available to us to be aggressive if needed. I think it's interesting that for heterozygous FH, the oral medications often are helpful. What about in homozygous FH? Obviously, this is far less common, but far more severe. Where are you going with this, and what are the tools you use to manage these patients?
So I think, for those who might be listening, if you really have determined that a patient has or likely to have homozygous disease, that conversation needs to start with someone who has experience with this, either in person or by telemedicine or whatever, because this is a very complicated and scary process. The morbidity and mortality is actually quite high, and it's going to take a significant effort to get that child's cholesterol level to go. So, typically we start with maximum dose tolerated statins and ezetimibe. Some will respond, most won't, because the major problem here is the LDL receptor is primarily non-functional, dysfunctional. And so you're going to have to escalate that therapy very rapidly. But point being is that those parents need to understand what the journey is going to be here. And it's going to be a series of very rapid changes, which, if you're dealing with a 3-year-old, is pretty frightening. And so it takes a lot of empathy, a lot of patience, and a lot of conversation. But that's why it's, in my experience, reassuring if families are talking to someone who's had some experience with this. It's not that the therapy couldn't be given locally. It just needs to be directed by, in my opinion, someone who's had experience with this. Because there are newer drugs, they're LDL independent, that actually work much better. Because in the absence of that, now the only other issue is the availability of it and the cost. But assuming those are in place, then I think you can advance the therapy in this day and age pretty well. The alternative to that is something like apheresis, which is very traumatic for a 3-year-old, and sometimes the vascular access is a problem.
Even Acumab, which is an ANGPTL3 inhibitor you were referring to, is now approved, from what I know, as early as age 1. Have you had much experience using it in your patients with homozygous FH?
We're in the process. We just have a new patient recently identified who is 3, I think.
So again, with statins, ezetimibe, PCSK9 inhibitors, not as effective in homozygous FH because of the LDL receptor inactivity or lack of activity. Even Acumab, independent of the LDL receptor, so a new tool that we have as early as age 1. And you mentioned apheresis, but obviously more invasive for a young kid. Although sometimes these patients need all of them. That's the problem.
Yeah, and that's what I said, that thoughtful conversation on the front end after you get to know the family and they get to know and trust you, is that you have to kind of lay out all the options. At least my style is not to kind of introduce those as you go along, because it sounds like things are getting worse, and perhaps they are. It just, You say, here's kind of the journey. We have lots of tools. But the exciting thing for you and I is that now we have tools that are LDL receptor independent. I think that's a huge game changer.
Exactly. I mean, I think about what we used when you and I started and what we can use now. It really does make our job a lot easier, which speaks to kind of also the importance of bringing other people into the fold. And one of the things I wanted to ask you, you're an endocrinologist, I'm an internist. The role of getting cardiology involved or early imaging in patients with homozygous FH with kids. I know that you folks are pretty aggressive about that, correct?
That's correct. So we don't typically do it with heterozygous disease. I mean, you can show that they have subclinical evidence of atherosclerosis, but it's not going to be obstructive or ischemic. But homozygous disease, I think you need to know where you are when you start, because unfortunately, many of these kids can have aortic dysfunction, aortic valve dysfunction, aortic root issues. In fact, we've had, unfortunately, kids in their, 5 years of age that have passed away from heart attacks. We have one child recently we saw in the clinic, that kid actually turned out to have Kawasaki's disease, but he's already had a CABG at 3 years of age. So you don't think about those things unless you do pediatrics, and then you don't even think about them unless you do what we do, right? But think about that, right? Your child's already had a CABG.
What about genetic testing? Do you do a lot of genetic testing or screening in your clinic?
We do quite a bit. We feel like that it actually gives a lot of information and confirmation. The trick to genetic testing is that you have to understand that, or at least the parent has to be told and has to understand in a meaningful way. We're not doing that to decide whether we want to treat the child with lipid-lowering medications, because as you well know, some of these are going to be negative. In the adult world, it's actually the majority. In children, you actually have a much better chance of turning up a genetic variant. But at the end of the day, we're not going to make the decision based on recommendations for lipid-lowering medications based on the genetics. The genetics is going to help us in terms of understanding lifelong therapies, how aggressive we need to get, and what the goals may be. It also is very helpful in terms of informing genetic counseling. So I'm a big proponent of that. And sometimes you find some very interesting things with genetic testing that you weren't anticipating. Well, for example, we just saw a child, that turned out to have cytostrolenemia. There's a 3-year-old that we were actually, working up because of opportunistic screening. But at the end of the day, the child was genetically negative, had LDL cholesterol levels of 350, and we said, well, something else has to be going on here. So that helped us because the treatment for cytostrolenemia, as you know, is quite different. Yes, I'm a proponent of that. I mean, there are some people who object to genetic testing for a variety of reasons, parents. Most of them in our practice is basically just expense. So there's a cash price that's much reduced, but for some of these families, even that is expensive. So
we've talked about heterozygous and homozygous FH. With regards to lipodystrophy, what are your therapeutic priorities? And have you been had any experience with metreleptin, which is a available therapeutic for folks who have certain types of lipodystrophy syndromes?
Yeah, so, ironically, as the listeners probably know, lipodystrophy, particularly generalized lipodystrophy, behaves like metabolic syndrome. Right, if you think about it, the fat's got nowhere to go, so it's going to go to the liver, muscles, in the myocardium. And so we've had some very unfortunate older children who died of myocarditis, for example, or just heart failure. But that's an advanced kind of form. So with the partials, you start looking for evidence of insulin resistance, and you do all the things that you do in metabolic syndrome. Metreleptin I have limited experience with, but at least the literature is encouraging in terms of it restoring, some of the normal or near normal metabolic functionality.
We've talked a lot about diagnosis, and we've talked about pharmacologic therapeutics. You've alluded to the importance of lifestyle over the course of the lifespan. So I just wanted to kind of go over some of the other strategies that can help both families and the children that you're seeing in terms of their long-term outcome and quality of life. I know you've talked about, upfront realistic expectations. But talk a little bit about family engagement, transitioning from pediatric to adult care, psychosocial issues, multidisciplinary care. I know you've spoken a lot about that to me in the past. Our listeners need to hear about this.
One of the things that we recognized early on is if you're going to tell a young person that they have a chronic condition, then there's potential for harm because you're talking to them about some serious conditions that they may have experienced in their family, either through their own parents or through their grandparents. So you have to put that in perspective. I think the important thing is you get to know the child, they get to know and trust you, and then you build that relationship and they can trust you. But we try to, I usually tell kids, Jamie, that you're here because you're healthy. We're just going to kind of keep you healthy. You're not here because you're sick in any way. You haven't broken your arm. You don't have a sore throat. You don't have heart disease. We're just going to keep you healthy going forward. But you're talking to 6, 7, 8, 10-year-old kids, and so you have to keep repeating that message. So now what you said is true. And by the time they get to be 16, 17, 18, we actually have them teaching our residents. So when the residents are with us, I say, look, can you teach this young person about FH? You have it. He needs to know it. And they do a fantastic job. The challenge is what you said in terms of how do we transition them? First of all, pediatricians are not very good about saying goodbye to their families because they've been with these kids since birth sometimes, but they do grow up just like our own kids, and then you have to get them prepared. But at the end of the day, besides knowledge, we make sure that if they've had genetic testing or they have any pertinent laboratories that we provide that with, we just give it to them. You need to take this to your internist, family physician, and show them that you have a genetic mutation because, a good strapping, athletic-looking female at 22 years of age, somebody may tell them, you don't need to do all that stuff. And then we also kind of go through the genetics of it with regard to reproductive health and the genetics of FH. Not to discourage them from having children. Everybody needs to make that decision independently. But just to put it in perspective, so if they've had genetic testing, we tell them, look, you can use this information if you like to identify a baby even at birth or shortly thereafter. Probably no need to do that quickly, but you can do it without biochemical testing by age 2. So we do try to hand them off to people in our community. The problem, of course, is perhaps like your kids, they take off. Right? They're going to go to college and, 6 states away, or they're going to go to the military service. Those are all great. That's what we all did. So it's a little bit hard sometimes handing them off to someone. For that purpose, kind of extend our care to kids in the young adult age group because we can do telemedicine visit, for example, if they decide they're living in Texas, but they want to go to college in New York or California or whatever. We'll do a telemedicine visit with them for a year or two until they made that transition. By that time, they kind of know where they're going to settle or where they're going to be.
I see some kids, generally the kids of my adult patients with FH, they'll often bring them to me, and I'll share the care with the pediatrician, so to speak. One of the things that I see often, I want to know how you deal with this, is when the parents come in with the child and say to me, you need to tell the child they can't eat all these foods. And the kid, of course, wants to be able to go to McDonald's or wherever it is they're going and eat the foods that all their friends are eating. How do you deal with that on a both behavioral, emotional, psychological basis? It's a difficult dynamic, and it can't be any easier for you.
Well, though, and shame on me, here's kind of what I do. When they say, tell my child that they have to do anything, I usually turn to them and say, I think you just did. And then I look at the kid and say, is she nagging again? And we do it kind of in a loving, kind of carefree way, because the point being is that that's the interpretation of any child when parents are consistently telling them to do anything, make up your bed, take out the trash, vacations, whatever. At the end of the day, I usually tell people that I take care of, the families that I take care of, do the best you can. Nobody's going to be perfect, but we need you to consistently do it some form of or shape of good, because this actually will benefit you long term. You just have to believe in the science of myself. And if we have that kind of relationship, you'll do very well. But at the end of the day, nobody's going to be perfect. If you miss a pill or two, no big deal. But we sometimes do the simple math, right? You have 30 pills in your bottle. You take one a day. At the end of the month, the bottle should be, and hopefully the answer is empty, right? So you got a nice way of actually keeping track of it yourself.
Well, I have to tell you, I always love talking with you, and I always learn something when we speak. The love you have for what you do shows every time you talk about it. You know, we really have had a great discussion today talking about why it's so important to recognize pediatric lipid disorders early. These are, in general, genetic or inherited disorders that have affected patients from the day they were born. And the earlier you recognize and treat, the earlier you can make a difference for long-term beneficial outcomes. We've talked a bit about diagnosis, distinguishing heterozygous from homozygous FH, and how to approach lipodystrophy, some of the diet and lifestyle changes that we want to initiate in kind of a supportive way with our patients and the families in the case of pediatric management, and then obviously stepwise therapeutics that we're now lucky enough to have for these LDL disorders, not just statins, but ezetimibe, PCSK9 inhibitors, and drugs that are independent of the LDL receptor, like evinacumab. Homozygous FH is such an important disorder to recognize, only because even in the first decade of life, children who are severely affected can have cardiovascular events. And so the importance of early and aggressive evaluation from the perspective of a cardiovascular consultation is important for these patients. Lipodystrophy, it's important to recognize. You can miss it. And there are some things that we can treat patients with now, independent of the supportive care, diet, and lifestyle that you mentioned. And then finally, the fact that when you're treating children, you're treating a family. And it really takes a group to manage everyone. It's not just the clinician and the patient, but it's the family members and all of the supporting folks that allow us to do our job, the nurses, the nurse practitioners, the physician assistants, the registered dietitians, the folks involved in social work, and even the exercise physiologists. So as always, it's been a great conversation, Don. Thanks for the excellent discussion. And thanks to our audience for listening. Please remember to take the post-test evaluation to receive CME credit. Also, please tune in for additional episodes within the series. Our next episode, I will be speaking with Dr. Dan Soffer about key considerations for the assessment and treatment of patients with severe hypertriglyceridemia. Thank you very much, and have a good day.
Thanks again for listening to MedEdTalks Cardiology. CE credit can be claimed through mededtalks.com. For other episodes in this series, search for Lipid Legends Season 2.